Hello everyone. Here is Samia Abbasi. Today my topic of presentation is bone marrow collection. Hello sir.
Yes.
Yes, today my topic of presentation is bone marrow collection. These are all objectives. I will cover all these objectives in coming slides one by one in details. So what is bone marrow? Bone marrow is the soft spongy tissue that fills the core of larger bones. It serves as an active function and it also produces three types of blood cells like RBCs, WBCs, platelets, as well as lymphocytes, which support the immune system. Next is sources of bone marrow. Uh, Clinically, transplantation is currently performed utilizing three major sources. First is peripheral blood stem cells, bone marrow harvest, and umbilical cord blood stem cells. I will cover all these in coming one by one. First is bone marrow harvest. Bone marrow is easy to collect, still the most widely recommended for related allogenic graft for non-malignant condition. In this case, less chance of GVHD and slow neutrophil plus platelet recovery and slow immune reconstitution. Second is mobilized peripheral blood stem cells. It is mostly advisable for autologous transplantation and currently it is extensively used for unrelated BMT. But in this case, with more chronic chances of more chronic GVHD, in this case, fast neutrophil and platelet recovery, fast immune reconstitution, and rapid engraftment. The third one is umbilical cord. So the third one is umbilical cord blood stem cells. It is readily available from cord blood bank, but it is expensive and associated with delayed engraftment. And it mostly for those children who have lacking a matched sibling, and the storage and delivery of umbilical cord blood to the transplant center require extensive quality assurance program. In this case, there is less risk of GVHD, and like bone marrow, there is delayed neutrophil platelet recovery and delayed immune reconstitution. So the next is types of bone marrow stem cells. There are four types of bone marrow stem cells: autologous, allogenic, umbilical cord, and the haploidentical. In the case of autologous transplant comes from the same person who will get the transplant. In the case of allogenic transplant come from a person other than the patient. And in the case of umbilical cord blood, the stem cells are removed from a newly born baby just after birth. And in the case of haplotype mismatched transplant, cells from a parent, child, brothers, or sister that are not always perfect match for HLA type, but they are 50% match. So this diagram show the allogenic transplant. These stem cells are collected from the donor, and then the bone marrow is sent to the lab for further procedures to purify and concentrate the stem cells, and then sometime the stem cells are thawed and then reinfused to the patient. So next slide. Yes, sir. Autologous transplant. In this procedure, transplant are mobilized, stem cells are mobilized from the bone marrow and then collected by a leukapheresis and then cryopreserved. And then cryopreserved and conditioning regimen given to the patient. and then we infuse this autologous bone marrow to the patient, and after 10 to 14 days engulfment occur, and then the supportive care. So this is the main slide that we that I that is related to my PPT, that is bone marrow harvest. Bone marrow harvesting involves collecting stem cells with the needle placed into soft spongy center of the bone, the marrow. Most sites are used copy hip and sternum, and bone marrow harvest is same for autologous and the allogenic transplant, and it is done from the iliac crust with a special needle and a syringe. So the next slide is collecting, processing, and storage. The main goal in this, the goal of hematopoietic stem cell is to collect the cell type, the matter, and they are measured. The most important cell type that matter in hematopoietic stem cells is CD34 count, because there are hematopoietic stem cells. In addition to that, T cell, B cell, and natural killer cells are also important, but mostly center counts CD34 cells count as per kg of recipient weight. If the facilities are available, we can do, if facilities are not available, we can do rough estimation of total nucleated cells per kg recipient as the formula. I will discuss the formula in the coming slide. Cell number that are used to choose dose is CD34 cell per kg per recipient weight, and total nucleated cells or mononuclear cells per kg recipient weight. So doses of stem cells vary by source. Since we don't have a facility to calculate the CD34 counts, so our method of collection would be based upon calculation of total nucleated cells, which we collect from donor bone marrow harvest in order to calculate estimated volume of hematopoietic stem cell collection during bone marrow harvest. This is the simple formula that there is. Should know the desired dose of recipient dose of nucleated cells per kg of recipient weight. That range from that range from 4 into 5 into 10 raised power 6 CD34 cell per kg per recipient weight, and can also be go higher. Debate about upper limit GVHD concerns. The other cell doses of cord blood T cells and post transferrin cyclophosphamide also in these slides. So the estimating target hematopoietic stem cells marrow collection volume, the desired recipient cell dose is between to calculate the volume of bone marrow harvest. The basic important that we have that the desired recipient cell dose is between 5 and 10 into raised power 10, 10 into 10 raised power 8 nucleated cells per kg of recipient weight, which may be increased to greater than 10 into 10 raised power 8 nucleated cells per kg of recipient weight. The target volume of collection will be based on the recipient weight and the dose. But in the case of the major ABO incompatibility, should be kept in mind that the target volume should be based upon recipient weight and desired dose, since red cell separation may imply cell loss, and harvest volume should be increased accordingly. Okay, the next slide is estimate target marrow collection volume. To calculate the volume of bone marrow harvest, the basic and important thing that we have, that the unprimed marrow contain 10 to 20 10 to 10 to 30 into 10 raised power 9 per liter, with an average value of approximately 20 to 10 raised power 9 per liter, which may increase to 40 into 10 raised power 9 per liter, or more than in the case of donor GCSF priming. If the recipient weight is 30 kg, the dose desired would be approximately 150 into 10 raised power 8 or 15 into 10 raised power 9 nucleated cells. Therefore, 15 into 10 raised power 9 nucleated cells or 0.75 liter is the targeted volume for collection. CBC should be sent from the donor afternoon prior to the harvest at 1 p.m. If the WBC's count are more than 40,000 per microl, then that's okay. But it's if it's less than 40,000 per microl, then the donor will be given instead of 5 microgram per kg, 10 microgram per kg per dose of GCSF at 11 p.m. the night before harvest. So the next is both the doctors and the registered nurse verify a donor card, check the appropriate consent for obtain, clear, make sure donor record including clearance for donation. The bone marrow harvest form is generated from the patient BMT plus main record at tab consent form, and also verify on the preoperative record, lot number, expiry date, and the name of the manufacturer for all the disposal supplies and reagents. The registered nurse and OT nurse prepare for patient and also make sure that appropriate personal protective equipment are available. And if more than collective, okay, dilute 5 unit heparin into a 100 ml normal saline to obtain a 50 unit per ml heparin solution, and adds 20 ml to collection bag after removing anticoagulant from the bag. And if the marrow is more than 200, then the another 10 ml of the 50 unit heparin solution is added prior to each extra 100 ml of marrow. Heparin is greater than or equal to 5 units per ml. The 50 unit per ml heparin solution should also be used for aspiration needles and collection, and also apply steady tape across lower buttocks to isolate buttocks folds, and two operators stand, one on two physician operators stand one side of the donor. Skin puncture per side are required. Because same cutaneous access may several times use marrow aspiration, and we drank small marrow aspiration not more than 5 to 6 ml in order to minimize dilution, with peripheral blood and hand to scrub nurse who will add to the collection bag via the three-way connector. And also the scrub nurse empties all syringes into the collection bag, flushes the primes entire syringes, leaving approximately 5 ml heparin solution before giving to the physician. So this is the bone marrow collection sheet, and we can take out this sheet from out BMT harvest sheet from our database system. Donor and HB of the donor and ABO compatibility, everything will be highlighted in this sheet. And we will add the volume that are collected from the both physician working on both side of the donor of collecting bone marrow harvest. HB has been mentioned. In addition to that, this harvest sheet also give us a targeted volume of collection for 5 into 10 raised power 8 per kg per, and the compatibility, blood group, and all the pre harvesting HB, etc. This sheet is important part in this regard. When bone marrow harvest is over, this transfer and filter the harvested marrow to the another bag. The another formula which we use for the dropping the HB for donor, that is donor pre-harvest HB into volume collected into donor weight is equal to actual HB. And the other simple and crude formula that we calculate the WBC's count, total cell dose total cell dose final product WBC count per liter into total volume collected, including heparin. And then recipient weight into 10 raised power 5 is equal to cell dose into 10 raised power 8. For example, WBC count is 1000 into 10 raised power 9 per liter. Volume collected is 150 ml and patient weight is 15 kg. Then the cell dose according to the above formula will be 10 raised power 8. So the barcode of bone marrow harvest, we can get it from our BMT plus by ordering new blood product in the form of bone marrow from donor, and from this barcode can be printed. This barcode can be printed and we apply it on the bone marrow harvest bag for maintaining the quality control of our collecting blood product. Then this bag delivered to blood bank where this bag is counter check before being issued to the patient for bone marrow infusion. And then the double check donor name and the MR number on label and ensure while in the donor name, volume collected, dose and volume of anticoagulant used, total marrow harvest volume, number of bags in sequence, as well as total number of bags. That is, if only one bag was used, write bag 1 of 1. In short, the label is complete. So this is the barcode we can get from the BMT plus by ordering blood product, and this barcode can be applied to the blood bank and then delivered to the blood bank. So the post bone marrow harvest donor nursing management related allogenic hematopoietic in the transplant, marrow donors typically recover in the BMT unit, and for a short stay for 4 to 6 hours. And typical complication may occur like pain, nausea, vomiting, or anemia. And after bone marrow harvest, the donor may experience mild to moderate pain, which should be assessed with age-appropriate scales. And depending on the degree of pain, narcotic and non-narcotic agents can also be used. And nausea and vomiting may indicate antiemetic agents. Vital signs should be checked at least early in the post bone marrow harvest phase, and blood count obtained 2 to 3 hours post bone marrow harvest or earlier if the donor complained of increased heart rate or respiratory rates. And prior to the discharge, the donor should be evaluated for any using hemorrhage from operative site and complete blood count obtained. And also iron supplementation should be given for 4 weeks, and also 2 weeks follow-up visit will be performed to ensure proper hematological recovery. So next is the autologous marrow cryopreservation. Procedure is almost same for both autologous and the allogenic transplant. But the cryopreservation in the autologous marrow, the filter the harvested marrow to remove bony specule, determine the volume of marrow collected, and temporarily store concentrated marrow at plus 4 degrees C. And using 50 ml syringes prepare 40 ml of 5% albumin by aspirating 10 ml of 20% albumin and 30 ml of normal sand. So the final the solution is 40 ml of 5% albumin. Slowly add to each syringe 10 ml of DMSO for final concentration of 20%, and then the transfer cryopreservation solution to plus 4 degrees C and allow to cool for 30 minutes. Before mixing, ensure all the bags, vial, and plastic box are labeled. Aluminum foil is also ready, and ice packs are properly placed in hood, which are covered by sterile drapes. Final DMSO concentration in marrow collection prior to cryopreservation should be 5 to 10%. And the next step is to divide the concentrated marrow into two equal parts and mix with cryopreservation solution in the cryo bags. And also take 2 ml of marrow with cryoprotectant and transfer 1 ml into two pre-labeled plain vial for viability and sterility testing. Arrange bags into aluminum foil, cover properly. Place foil covered bags in pre-labeled plastic box and store in -80 degrees C. Prior to starting conditioning, check viability by trypan blue cells viability assay, as well as microbiological culture and thought sample. So this is the chemo hood that we use for preparation of chemo and also for cryopreservation of the autologous. Storage of cryopreserved product. Written consent for cryopreservation, and it should store normally for a period of 6 months. And at the time of expiry, the nurse will check the program director before ordering disposal of expired product. And also vitality of the product will be checked prior to disposal. Parents will be notified before discarding the product by a letter. So re-infusion of autologous marrow. It should be pre-med the patient, with 0.1 ml 0.1 ml per kg Avil and 15 ml 15 mg per kg oral paracetamol, and ensure good intravenous access as the third product needs to be rapidly administered. And also make sure that the CVC lines or the peripheral lines are in working condition. Also the biopsy cabinet and hood, and get number of 50 ml and 20 ml syringe open and ready inside the hood. And also indication given already that the peripheral lines and the CVC lines are in working condition. Also make sure that the three-way attached to the lines, and also all pre-infusion observe notice. One nurse remains bedside the patient all the time. And also make sure that the oxygen is available, patient connected to the cardiac monitor, and saturation probe is attached. So the monitoring the patient post infusion for cardiac arrhythmias, for hemoglobinuria, hematuria, nausea, vomiting, flashing, dyspnea, chest tightness, diarrhea, headache, etc. And also check electrolyte by blood gas and label at 1 hour and 4 hour post infusion. Continuous cardiac monitor and saturation monitor for 6 to 12 hours after the infusion. Blood pressure every 15 minutes for the first hour, and then 30 minutes for the next 4 hours, and then hardly as long as indicated. So the overall nursing responsibilities in both in case of allogenic and the autologous marrow collection: before the procedure, the physical preparations, and also provide clear explanation. Make sure the puncture site has been cleaned. Check vital, prepare, and also check vital and prepared equipment. During the procedure, the nurse help the patient to remain in the right position, assist the doctor in the procedure, prepare the equipment, and hold the patient, monitor vital sign during procedure to detect complication. After the procedure, the nurse should observe the pressure dressing is tight, clean, and no sign of bleeding to prevent infection. Observe the donor until their condition stable and recover, and monitor vital signs after the procedure. These are the references of my presentation. Thank you so much for listening, and thank you, sir, for sharing slides.
Thank you, Samya.
That's it, sir. Thank you, sir.
Thank you. Any questions? Okay, then let's move on to